Thank you, Lenny. I was asked to make some comments on toxicity in pediatric regimens. So the obvious trial to focus on today is the AALLO232. And basically what I'd like to cover today, I want to give a brief overview of the clinical trial. And then I wanted to talk about toxicity on the trial from two different dimensions. One is to look at the toxicity based on regimen and phase. And the other is to look at by age. That is to compare toxicity in the AYA group compared to the younger group. And then finally to talk about outcome. So I don't think I have to tell anybody in this room that AYA patients with ALL have an inferior outcome compared to younger patients, that is, patients ages 1 to 15. And this is due to both higher relapse rates and higher toxicity. And I think probably everyone in this room is committed to trying to tease out some of the issues in the third bullet, and that is the various differences in disease biology, host factors, treatment, and complex socioeconomic factors, for example, compliance with chemotherapy, which we know is incredibly important, and that's been demonstrated time and time again. So the objectives for COG AALLO232, first and foremost, was try to improve the overall outcome for children and young adults with high-risk ALL. The two basic approaches was to compare dexamethasone and prednisone during induction and to compare high-dose methotrexate to Capezi methotrexate during intermittence. I think you heard this morning that some of the background for this was a sense that maybe we were drifting towards a relative higher prevalence of CNS relapse. So both the inclusion of dexamethasone and high-dose methotrexate was planned, at least initially, to improve CNS control. We also, during the development of the protocol, had a great degree of concern over toxicity, both for dexamethasone and high-dose methotrexate. And that's what I'll be covering today. Eligibility was fairly straightforward. This was newly diagnosed B-cell precursor ALL. It was NCI high-risk patients. That is, patients 1 to 9 with a white count over 50,000 or age 10 to 30 with any white count. Patients identified to be very high-risk ALL came off protocol therapy after induction. These included patients who were pH positive, severe hypodiploidy, induction failure, and MLL rearrangements with slow early response. So here's the schema. In red, we have the two areas of randomization. Patients were randomized during induction to 14 days of dexamethasone versus 28 days of prednisone. The reason for this, initial discussions, we were talking about a full 4 weeks of each. There was concern, and there's some data from Dana-Farber, that a full 4-drug induction in patients was associated with high mortality, so I think our compromise position was to go to a shorter course of dexamethasone. So it's important to keep in mind that these patients received either 2 weeks of dexamethasone or 4 weeks of prednisone. Patients went on to a fairly standard consolidation, and then during intermittence, patients, again, had been randomized up front to receive either escalating Capezi methotrexate versus high-dose methotrexate. And it's also important to keep in mind that traditionally the escalating Capezi methotrexate also included 2 doses of asparaginase. And I think that'll be important when we look at some of the toxicity data. Patients then went on to a delayed intensification phase, which was basically a blend of induction and consolidation. At that point, there was a bifurcation in patients who had slow early response based on morphology or end induction MRD, went on to receive a second interim maintenance. In this case, all patients receiving a second interim maintenance received Capezi methotrexate, followed by DI, and then on to maintenance. Those patients who had a rapid early response went directly to maintenance. The duration of therapy was based on the time that you start interim maintenance. That was 2 years from the start of interim maintenance for girls and 3 years for boys. So the overall duration was roughly 2 years and 4 months for girls and 3 years and 4 months for boys. Patients, there were subsets of patients who received cranial radiation. CNS3 patients received cranial radiation, and we also, at a dose of 1,800, and patients who were slow early responders received 1,200 of cranial radiation. In terms of study history, it opened in 2004. It closed prematurely in January 2011 when the methotrexate randomization crossed predefined interim monitoring boundaries. There were 2,571 eligible evaluable patients randomized. And as I mentioned this morning, we had a fairly good representation of the AYA population, 20% of patients aged 16 to 21, and again, a much smaller number in the 22 to 30-year age group. So first I'll talk about toxicity as a function of regimen and phase. And as I mentioned before, we were very concerned about toxicity during induction, particularly in those patients randomized to dexamethasone. There were some laboratory abnormalities that were noted that I've outlined here. And these include higher rates of hyperglycemia, hypoalbuminemia, and also hyponatremia in the patients who were randomized to dexamethasone. In terms of clinical outcome, we were very concerned about the possible increased risk of infection in patients who were randomized to dexamethasone. And you can see in the red arrows here that there were, in fact, higher rates of both febrile neutropenia and infections in the dexamethasone-containing arms, but there was no increase in grade 5 infections, no increase in induction deaths in the dexamethasone versus the prednisone. So this was felt to be an acceptable toxicity in this regimen. Interestingly, at least to me, one of the toxicities that we were monitoring very closely, and we've always monitored very closely, largely to the champion work of Len Matano, was osteonecrosis. And we've been, at the same time, trying to escalate therapy and improve EFS for our patients. We also recognize that a lot of our patients, particularly our older patients in the teenage years, are getting osteonecrosis. So this was monitored very closely. And the study was suspended briefly in 2008 due to an unacceptably high rate of osteonecrosis. And when we looked at this, this was happening in the older patients, that is greater than 9, who had been randomized to receive 14 days of dexamethasone. And these cases of osteonecrosis was much later in therapy. They were typically in early maintenance, sometimes in delayed intensification, but months away from 14 days of dexamethasone. So it was really quite surprising to us. At that point in time, we closed the steroid randomization to older patients and retained the steroid randomization for younger patients, and the osteonecrosis rates in the older patients then returned to baseline. Consolidation toxicity, there was no randomization in consolidation, but there was some concern there may be some residual effect of which steroid you received during induction, either putting you at risk for infection or possibly having a protective effect in allergy or anaphylactic reaction to your second dose of asparaginase is when you usually get your first reaction. And I've just boxed in the p-values. In any parameter we looked at during consolidation, we saw really no difference between what steroid you received during induction. So I apologize, this is a pretty busy slide, but I'll just highlight what some of the major findings are. In terms of laboratory findings, this is interim maintenance, so we're comparing Capezi methotrexate to high-dose methotrexate, And patients who received high-dose methotrexate had higher rates of elevations of ALT and AST, whereas patients with Capezi methotrexate randomization had higher rates of bilirubin. And also keep in mind that these patients had also received asparaginase during the cycle, so that may be an explanation for that finding. In terms of clinical findings, there was concern about differing rates of mucositis, and we saw mucositis rates of around 14% in both arms. Keep in mind the patients with high-dose methotrexate did get leucovorin rescue, and the patients with Capezi did not get leucovorin rescue, so that may be an explanation for the equivalence there. Febrile neutropenia was much higher in the Capezi methotrexate arm. Again, we're probably going to implicate asparaginase and some of the myelosuppressive effects of asparaginase. So now I'm going to shift a little bit, and we're going to talk about some of these same toxicities, but rather than talking about which regimen you were on, we're going to look at the younger patients, that is patients less than 16, and compare them to the AYA patients defined as greater than 16. And again, about 20% of our patients were in the older group and 80% in the younger group. So this is induction toxicity. And as you can see, and I think we've heard this presented by different speakers earlier today, we're seeing higher rates of hyperglycemia and hyperbilirubinemia during induction. Again, this is a standard 4-drug induction. We talked about the steroid. We have the daunorubicin, vincristine, and asparaginase. No differences in anaphylaxis, pancreatitis, thrombosis was interesting. We thought we may see some differences there, but nothing of any statistical significance. And then, interestingly, you look at febrile neutropenia. That was actually higher in the younger age patients. And the good news in terms of induction mortality, there was an equivalence there and no increase in the AYA population. Turning now to post-induction toxicity, if you look at mucositis, and this is happening predominantly in the interim maintenance phase when patients are getting methotrexate, we see a statistically significant higher rate of mucositis in our older patients. And we also see a statistically significant higher rate of motor neuropathy in our older patients. And I think neither one of these were particularly surprising. Just as we saw higher rates of febrile neutropenia in our younger patients during induction, we saw the same trend in the post-induction period. But what was most striking and concerning to us is if you look at death in remission, there was a 4.4% rate in the older patients compared to 1.8%, and this reached statistical significance. In terms of outcome, this slide demonstrates event-free survival, and the event-free survival on the top is the solid line is for the younger patients. It's coming in at 81% compared to 68% for the older patients. And if you look at overall survival, the younger patients had an overall survival at 5 years of 88% compared to 79%. In terms of treatment failures, patients older than 16 had both higher rates of relapse as well as higher rates of death during remission. Interestingly, when you tease this out and look at it, was there any particular regimen that was better for the AYA patients? There was a trend that was clearly not statistically significant, but if you look at the regimens, which are indicated, the first letter being what steroid you received during induction, D for dexamethasone, P for prednisone. The second letter is for the methotrexate you received during interim maintenance, Capezi or high dose. there was a suggestion that there might be a protective effect of the pH arm, that is getting prednisone during induction and high-dose methotrexate during intermittence. So in terms of conclusions of toxicity on AALLO232, AYA patients during induction have higher rates of hyperglycemia and hyperbilirubinemia, lower rates of fever and neutropenia, and comparable induction death rates. AYA patients during post-induction have higher rates of mucositis and peripheral neuropathy, lower rates of fever, neutropenia, and higher rates of remission death. In terms of future conclusions, I think these findings, both with the outcome and the toxicity we saw in our older patients on AALLO232, I think tells us that strategies aimed at both improved leukemia control and reducing overall treatment toxicity are likely to continue to improve the outcome for AYA patients with ALL. In terms of thanks, I mean, obviously the thousands of families and patients who participated in these trials, thousands of nursing healthcare research associates that were involved in the trial, the ALL study committees, Jim Nachman, who was a treasured mentor to me and also an AYA champion himself. And I'd also like to thank Steve Hunger and Peter Adamson for their leadership in COG. Thank you.